And as I said earlier, you don't need a license to gain knowledge. We just need to know how we use that knowledge appropriately within the scope of our practice. Hello, everybody, and welcome to the Polestar Pilates Hour. It's funny, I was going to say the Polestar Pilates Lab. We were just talking about the pathokinesiology labs. I'm super honored and excited to have a dear friend of mine, colleague, leader, example, Dr. Rob Landel with me today. Rob, good to have you on the Pilates Hour. We
Thanks
just
for having me. I'm really looking forward to it. I've been looking forward to this with anticipation for a couple of weeks ever since you asked me. So yeah, I'm looking forward to this.
and I get to go down to USC every summer and participate in one of Rob's courses. Rob is a professor at USC in the Division of Biokinesiology and in the program, the Doctor of Physical Therapy program, and has also been department chair of that program and now educator, facilitator, faculty, leader, all of the above. He also has been a big mover and shaker in the profession of physical therapy and is a fellow of the Academy. So good to have you. I we get to talk all the time, and you and I we have history of being up until 3, 4 in the morning in New Orleans with Dr. Alan Lee when we were very young, and I had a full head of hair. So that means it had to have been a long time ago. Rob, tell a little bit about your story, just your interest in not just physical therapy, but sort of the idea. Today, I want to really focus on movement science, pathokinesiology. Uh, uh, Everybody's heard me use that term on this program before, and pathokinesiology term, as far as I'm concerned, had its roots at USC with Helen Hislop back in the day, and I had heard her speaking when I just graduated in '89. And would love to hear you tell a little bit about your story, your journey, as we get to sort of that stage in our career where we have many more years in the career than any other aspect of our life. So um, would love to hear your thoughts.
So I feel a lot of times like I'm the Forrest Gump of physical therapy. I've just been in the right place at the right time, accidentally, over and over and over again. So you're talking about Helen Hislop. She was one of my professors. She was the chair of the program when I was here at USC. She was actually my research advisor as well. I got to experience a lot of red ink in my proposals and things. I went from USC. My first job was at Rancho Los Amigos, at that time, medical center, and spent 3 years there. And I was, again, Forrest Gump. I worked with Dr. Jacqueline Perry, who actually created, I think, probably one of the first biomechanics labs at Rancho. It's actually called the Pathokinesiology Lab. We always call it the PK Lab. And that lab served as the model for a lot of other labs that have sprung up around the country since. I went from Rancho and working with a primarily neurologic population for most of my time there to an outpatient orthopedic clinic, and had to sort of dust off all of my orthopedic skills, but also took a deep dive into relearning them, and trying to get better at them. But I was able to marry, if you will, the skills and the approaches that I developed working with neurologically involved patients to patients with, simply, musculoskeletal issues. And that led to a great interest in me and sort of breaking down that wall between the neurologic PT and orthopedic or musculoskeletal PT. Along the way, I started teaching at USC now, 36 years ago, a long time ago. But, I was 10, so it's, in terms of my interest and experience with Pilates, it started actually and this is how Brent and I met, when I was trying to start our faculty practice here at USC. It was one of the first faculty practices in the country. Didn't really have a model to go by. Just did what I thought was best. And one of the physicians here wanted to start a Center for the Performing Artist, and he came up to me very excited one day, and um, about this exercise thing that dancers did, and you're a PT, you should know all about it. I go, what are you talking about? And he didn't even know the name of it at the time, and this is way pre-internet, so it wasn't something you could just go sort of look up. So I just brushed it off, and a few weeks later at the California PT Association meeting, I wandered into a session, and here's this guy talking about this exercise thing that dancers do and how PTs can use it. And that was Brent, and that was Pilates, and that was my first introduction to it. So again, Forrest Gump my way into Pilates. Fast forward about 20 years, and had a private client who had her own Pilates instructor, and the Pilates instructor, was having some hip problems. So I took a look at it and helped her out. And she said, I've got like 3 clients right now who have similar problems. I don't know what to do with them. And that led to me actually establishing a cash-based practice in her Pilates studio. And the two of us worked together for a number of years. And I thought it was fantastic because I could take my clients and, work on their mobility and things like that. And then I could turn around and say, hey, could you help me out? I need to follow this, what I've just done with exercises that would help do this, or move in this plane, or work on this muscle or this movement. And she'd go, and she'd have like, 25 different ways to do that. And conversely, she was not trained, in say movement analysis, or not a lot in anatomy and so on, but she had a phenomenal eye. And she would say, when I watch, this client, she does this, and and I go, oh, let's work on this. And so she would send me her clients, we work a little bit, and then they go back to exercise. And again, Forrest Gump my way into that practice and that relationship. That was very enlightening for me, and I hope very enlightening for her as well. So
Well,
yeah.
that leads us into so many of the topics that I want to talk about today. I mean, the first one, let's go back to Helen Hislop and thinking of that experience with her. And I mean, I found out later that she had moved to North Carolina just before I did, and she had passed away here in North Carolina, is my understanding. But she had some friends at Duke, and they speak very highly of her and just loved her to pieces. And I always saw her as a little bit rough when I met her the first time, but she was like, I'm leading this profession and you'll listen to what I'm going to say. Of course, I was a brand new grad. And, but I was so impressed with the philosophy of pathokinesiology. And it was like everybody being asked, are you going to go into neuro? Are you going to go into ortho? Are you going to do peds? Are you going to do Jerry? You're going to work in a skilled nursing facility? What are you going to do? And it's like, and I was like, I'm that's not really, I'm trying not to think that way. And because I had the dance background and I had the Pilates background before I even graduated, it came in Pilates, we were taught, we look at the whole body, we look at the whole person. It doesn't matter what package they bring with them, we look at the whole person. So when Helen said, you know, we want to be able to define what we do as physical therapists, and she said, we came up with a phrase that we're pathokinesiologists. Any pathology or trauma that impairs movement is our specialty. And, I've embraced that. And of course, I went the opposite route. So I did all the ortho, which we had gone through a number of our manual therapy trainings together, similar pathways, similar programs. And then when I went to get my PhD, they made me teach the neuro rehab course for a couple of years. So I had to go completely backwards. And of course, all the people you're talking about are the pioneers. And so those that don't know, the names that Rob was dropping of his Forrest Gump experience are like the pioneers, the people that wrote the book for neuro rehab and for sort of the development of our profession over the years. So incredibly fortunate to be with a number of those people at USC and Rancho. So to me, I want to just ask a couple questions like, how do you interpret it? Like we've talked, you have pathokinesiology labs, the idea that it's not, I'm a orthotherapist or I'm a peds therapist, but it's like, how do we make the concept of being the generalist and that our actual specialty is in movement and movement impairment as a result of pathology?
So who depends on the audience, right? A little bit. I think our our being our profession in PT being our biggest audience, or the audience I think we need to reach the most, are payers and legislators, and having them understand that this is what we do, and that we talk about the movement system, which so you have the cardiovascular system, musculoskeletal system, neurologic system, and the movement system. Well, the movement system doesn't lend itself to those anatomical divisions, right? Like the cardiovascular, we don't, movement systems includes all of those, everything that involves movement. And it's a little hard, not a little hard, it's hard to wrap your head around that
The whole
thought
thing.
process. Yeah, the
Mhm.
whole thing. But I think that's the way to package it. And the other difficult thing for us as a profession internally is we're still understanding what those systems are, right? So we're starting to understand better how central nervous system and attitudes and perceptions involve or affect movement. So, for example, a very simple example we've known for a long time, that fear of falling will limit how you move,
Yeah.
right? So that's an attitude, that's an experience, that's a fear avoidance behavior, and yet it affects how we move. And as movement specialists, we have to understand that and figure that out and address it.
Yeah, I was so glad when we started seeing a lot more publicity of the research of the psychosocial, the biopsychoneuro components that impact movement. And this is sort of my pedestal as well, as just saying, like, we have to understand normal movement and its relationship to all systems. And then when we understand how pathology impacts those systems that impair movement or impact or influence movement, we become the skilled practitioner. We could have a specialty of talking about, I'm a movement practitioner and I specialize in working with a population that has trauma or neurological disease. Or I'm a movement practitioner that specializes in working with musculoskeletal systems or with pelvic floor kind of thing. So I do think, it's like you said, um, there's so much knowledge. And this is something we try to convey in our Pilates education is like the amount of knowledge we need to be proficient in movement education, healthy movement education alone is huge, right? We talk about the biopsycho, we talk about the neurological, and that was my dissertation 20 something years ago, was um, looking at the psychobehavioral components and the physical limitations as they were predictors of outcome with low back pain. And it showed that the psychobehavioral stuff was a much better predictor, like you were talking about fear of falling of behavior. And as physical therapists, we were always looking at the physical limitations. Do we increase the range of motion? Do we increase strength? Do we increase girth? And they didn't have a correlation with the functional outcome. Even though they were good and they were better, they were not good predictors in low back pain. And yet the psycho was much more powerful, behavioral psychological. And so what we learned was that in movement, if we can create these experiences, these positive movement experiences, we can shift that belief. And if we shift the belief, then we have a predictor. And so, that being said, looking at now, let's say we're talking to the half of our audience that are really skilled movers, like you had talked about with your partner that was, I believe, is in Malibu, right? Was she in Malibu?
Yep. Yeah.
She was in Malibu. I remember those days. But looking at this relationship that should exist in the continuum of movement wellness. And there's the aspect of it where we're in this pathokinesiology and transitioning into performance kinesiology. How do we continue to prepare ourselves? One of the walls I'm trying to break down is the fear of the Pilates teacher of having enough knowledge to be able to just communicate directly with physical therapists, and physical therapists to lower their ego a little bit so that they can be approached and have the relationship that you had and that I have, and the benefit that comes from that. And you had said a couple things in your opening comments of how you realized that she had such a sharp eye for movement. And if we're not involved in that, like I would assume if you and I watched a couple rounds of beach volleyball. By the way, Rob is and his whole family are deeply involved with volleyball and beach volleyball, and take family vacations to go have tournaments and win everything and take the gold, the bronze, the silver, and the bronze. But it's like if we were to do an analysis of volleyball games, you would have every detail there is about volleyball because of all the years that you've been involved in the sport and your profession. But the minute we look at other movement forms, like how do we become proficient in those movement forms and being the one that's looking at it? And this is where, I'd love to hear from you a little bit of your thoughts of this continuum of establishing a language, a common language that we can use or that you use with the Pilates teacher in Malibu. What's the common language that we can start building this bridge in the interest of the client more than anybody else? Like if we could remove our ego from it and said, look, this is what my specialty is looking at movement pathology. And maybe I have a subspecialty inside movement pathology, right?
So I think Brent was asking me about a common language and how we might approach that and put our egos aside. I think that I'm going to speak from personal experience, and my experience comes from the pathokinesiology lab at Rancho. In my experience there, gait analysis, observational gait analysis, or the Rancho version of that was figured very prominently in my education and how I go about watching people move, in which you break down movement. In this case, if you watch somebody walk, you can break down human walking into what's going on at the different joints, and you can at each joint what happens in a particular point in time. And the gait cycle has been broken down into two major aspects: stance and swing phases, and then those are broken down into sub phases. And we can talk about what's happening in each joint in each of those sub phases. We can talk about what the muscles are doing. We can talk about what the demand at each joint is, which causes then the muscles to react. And we can talk about what the critical events are. So, for example, in loading response, we need to absorb, the critical event is to absorb the contact with the floor. And we do that by flexing the knee 15 degrees, by plantar flexing the foot, the ankle 15 degrees, and so on and so forth. And that causes then the quads to function eccentrically. And so, you could break it down joint by joint, demand by demand, by phases, by sub phases, what's going on. And I think we can apply that. I know we can apply that same process to basically any movement that the human body can do. So we have a class here that's taught by Dr. Chris Powers and Dr. Beth Fisher. It used to be a biomechanics class, but now it's a movement analysis class. It's actually a 1-year class, two full semesters. And what we have the students do is break down movements into component phases and identify what's going on in each joint during those phases, and then what are the demands, what are the critical events. And I was teaching in the 3rd year for a long time, and I took students and I gave them a novel task in that 3rd year. So they have this movement class in the 1st year, and 2 years later, I gave them as a group. There are 8 groups of students, and I gave them a task to break down a novel. And it was interesting that the 8 groups broke down the movement into very, very similar phases and very similar cutoff points for each phase, and then also what the critical events were. So I think that's a way to go about creating a language of movement. What happens when we do whatever the task is? What are the important things that happen during that task? So, for example, one of the things I asked them to do is break down a surfer getting up on the surfboard. And well, at first he's got to extend his arms, and then he's got to get his feet under him, and then he's got to stand up. So everybody broke it down into those 3 sub phases. And okay, what has to happen? Well, we have to have back extensions, arm push up, and then we need to shift the feet underneath the center of mass, and then they need to bring the center of mass up and be on the board. So that's an interesting way to sort of break things down, and I think will probably prove to be a useful way. And it's agnostic to profession. It's agnostic to um, to pretty much everything. It's just sort of, this is how people move.
I love that because I think of the task orientation, right? So it's like when we even look at the ICF model, for example, and the center of the ICF model, nobody owns the ICF model. It's the World Health Organization's model for all of us to use. But I always tell the students right in the middle of it is activity. And if we think of activity now, you said surfing is the activity. How do we break that surfing activity down into its very task? And then how do we identify do they have coordination? Do they have the proper mobility? Do they have the proper power to be able to move into that direction, to push themselves up off the board? And immediately our brain starts working of thinking like, oh, in the Pilates world, we have, 4,000 variations of exercises on the equipment that we could very easily address those tasks and those things. And that could be the common language that we use. I think that even in the Polestar curriculum now, we've incorporated the ICF model for everybody to have the ICF model so that we can talk about the activity and the task, and then know that the upper part of it is dealing with the pathologies that are causing or influencing the activity. And that really belongs to the medical professional, the healthcare professionals understand it. But I've been sort of making up a phrase of like, look, you don't need a license to have knowledge. And I think that if we look at the ability of everybody to increase their knowledge, then we can communicate and create these frameworks that you just presented very eloquently of looking at the task, looking at the activity, looking at maybe some principles of movement that we talk about in Polestar, where it's like, do they have the proper coordination, power, control, mobility, coordination? So and those are things that the majority of the Pilates teachers can work with, almost all of those, except for structural mobility limitations. And that's sort of where I always feel like we go back and forth. And if we're communicating the same way, even if you and I, and this is what you were explaining earlier, if we do a manipulation or we do a myofascial release or some needling to be able to restore some movement, they still need to go back and have the strategy laid on top of that new movement they acquired.
Yeah, I always say that, and Brent, this, I've spent a lot of time learning manual therapy techniques and perfecting them. And I've pursued a lot of different approaches in my career. Given the time that I've spent, you could call me a manual therapist. But I will be the first one to I tell my students this straight up, is manual therapy is very, very important, but it's the adjunct to the real therapy, which is exercise, which is movement, right? So you give somebody some mobility, either in the soft tissues or the joint, that's relatively useless unless they can use that, and now they can access the movement. Now we have to teach them how to access the movement. And this is the way, by the way, my Pilates partner back in the mid 2000s, Edie Azar, that's what she was so good at, right? So I said, now I've given this, my client some hip extension. What are some exercises? Oh, we could do this. We do this. She had like, a bazillion ideas. And the more ideas you have, the less stale it gets for the client, right? And so here, we're going to do these exercises. You're still working on your hip extension. That's a different way to do it. You're a little bit more engaged. You're more likely to do it, which leads to better outcomes. And it's just a better approach, I think, all along. But the idea, is figure out where the issues are. Watch somebody move, do their activity, and hypothesize, if I compare this to maybe how someone does this more optimally, where can I hypothesize the issues are, manage those issues, and then get them to move in a different way. So I had another Forrest Gump moment. I was working at the US Olympic Training Center in Chula Vista, as part of my prep to work with USA national teams, and the some of the track and field athletes are resident there, and I was working with a pole vaulter, and this would speak to you, Brent, as a pole vaulter. But I had no idea about pole vaulting. I mean, I watched it, but I never really thought about it too much. And that night I went, YouTube, awesome, is an awesome tool. I spent like 3, 4 hours on YouTube watching pole vaulters, high level pole vaulters. And I did find one that actually broke it down into phases. I go, great, this is exactly what I'm looking for. And I was able then now to watch her do her event and break it down. And I go, oh, maybe this is where your issues are. And let me check. Oh, hey, yeah, you have a mobility issue here. You have a strength issue there. Let's work on this. Let's work on that. And was able to help, even though I was a novice to the sport, I was able to break the movement down and still find a way to help her out.
That's something really important too, is doing the investigation. I think, when we look at the skill set, there's a question on the docket there from Irena talking about the application of these things more to the other movement professionals in the industry, and really thinking of, there's often I find the Pilates teacher, the geratonic teacher, the yoga instructor, the Feldenkrais instructor, the Tai Chi instructor, that they have such a stronger eye of looking at whole body movement, and they have a very sharp way of identifying things and seeing things that are unique and picking things out that we often would miss. And I often refer to that as the qualitative movement versus the quantitative movement. We're often in the medical profession, we're looking to quantify movement. We want to know what their range is. We want to know what their limitation is. But I love the idea of being able to go back and look at YouTube videos of somebody comes in, they're a golfer and they want us to help improve their golf game. And you're going, I don't know the slightest thing about golf. Well, you start learning, because if you learn some of the fundamentals of it, our knowledge in movement, our knowledge in physical therapy, our knowledge in assessment, our knowledge in observation, whatever profession we are, as movement professionals, we'll use that term, we're going to see things like you saw with the pole vaulter, things that could be improved, right? So it's the approach, the drive, the swing phase, on top, the push off, right? Each of those phases takes about a year to learn how to do in pole vaulting. The other one that I always found interesting was dancers, right? So, I worked with, performing artists forever, and it was always interesting to me. Somebody come and go, I really want to work with dancers. And I'm like, why? Like, are you a dancer? No, I was never a dancer. Do you like being poor? No, I want to make money. Why? Why do you want to work with dancers? Do you like working on weekends and nights and people that are very set in their ways that are, it's like, no. I said, okay, well, you might want to think about it. And I think whenever we look at things like really diving in, it's like, go take a dance class, go watch a ballet, go watch different artists, watch things on YouTube and understand what these bodies are going through. And then you're going to have a better idea, because of our movement background, how we can help them. And I think that's really, really good advice. And I wanted to talk a little bit more about the continuum, and I don't want to beat it to death, but the idea of the patho to the performance, because I think this is where we get stuck a lot of times. And Pilates teachers that are really in tune with their scope of practice are often afraid to do too much in the rehab field. And, the rehab world doesn't really have the energy or time or capacity to be moving a lot into the post-rehab world. And it's like, it's really nice to have the ability towards the end of that patient's care to be co-treating, co-working with somebody in the community that is teaching really good quality movement, whole body movement. And maybe share a story or two, another story or two that you had with the studio in Malibu where that was manifested, where your expertise and her expertise really gave the client the best experience, and how you sort of work through the process of communication so that
So
was
yeah,
here.
so a great example. So as I mentioned, Edie said, "Hey, I've got 3 clients who have hip problems similar to mine. I don't know. I'm working through them with exercises, but they still have these problems. Can you take a look?" So and one of them in particular, so yeah, my surgeon says, I need to get a total hip replacement.
And I looked at the X-rays, and okay, they didn't look great, but I looked at her mobility, and I think we can let's just see. Let's just see if we can get some mobility back. Okay. And then, if you need surgery, you're already, going down that path. But my job as a PT is to try to avoid surgery if we can. So let's give it a try. Are you game for that? She said, yeah. So worked on her hip mobility, did a fair amount of mobilization to the joint, and then worked with Edie to say, okay, when when she's in your class, can you focus on these movements? I didn't really care how, what exercises in particular, but here's the movement that I really want. I want some rotation. I want some rotation with the hip extended. I want some rotation with the hip flexed. Some minimal weight bearing exercises, and maybe up to full weight bearing, bilateral weight bearing. And eventually we, worked into full weight bearing, so single limb weight bearing kinds of things. And are there things that you can do? And she goes, oh, look at this, got this, got that. On the reformer, on the mat, we could use a chair, we could use one. And I'm like, great. And then I would just sort of sit back in awe and sort of watch her work,
Yeah.
watch her do her magic. And over the course of, memory is what it is. I want to say it was pretty quick, but it was probably 3 or 4 weeks. And she's like, yeah, I don't really think I need the surgery. And in 6 weeks, she goes, I'm gonna cancel the surgery. So my hip, in other words, my hip feels great. I'm walking on it fine. I don't have pain. I can go hiking. And again, going back to her activities, what do you want to be able to do? And was hiking the hills, walking her dog. I don't think golf was a big thing, and this is way before pickleball. But it was like, I want to do these things. And well, how are you getting along with those? I don't think I need surgery. I can do these things. So that's I think as a PT, I tried to communicate as best I could. Here are the movements that I think would be helpful. Here are the conditions: weight bearing, partial weight bearing, slightly weight bearing. She did a fair amount of strap work as an example, so a little bit of weight bearing, but a lot of relatively open chain kinds of exercises. So the conditions under which to exercise and the movements, and she took that and ran with it and developed this phenomenal exercise program for her that I got to watch. I'm working with my next client, but I got one eye on her and what they're doing. I go, oh, that's awesome. That's
Yeah, I'm
you
so
know,
glad that you had that experience. I mean, this has sort of been with Shelly Power and myself, this has sort of been our life over the last 30 years together of having that communication and that positive experience. And it's good to see other, and I know many do. We have a lot of, physical therapists that go through our training. Probably about 40, 50% of our graduates are physios. And we want to embody this ability to have that communication. I think you said something really interesting. It was like, I know as a physical therapist what mobility and movement or power that I want to see restored or to be focused on. And then you trusted Edie to be able to come up with the repertoire. And I think this is very similar to us and physicians, right? So it's like if it's a movement pathology, all we really want the physician to do is say, here's the diagnosis, evaluate and treat. Like the last thing we want is for a physician to tell us that we need to do quadruped exercises and some core strengthening and some hamstring. Like if we see that, we want to throw up. And I think that Pilates teachers feel the same way when a physical therapist tries to tell them how to do exercise to do, but they do much better when we say a guideline, and more importantly, even I would say the contraindications or precautions that might exist in movement, right? So we have somebody with pretty advanced osteoporosis, but we're really interested in working on that hip that you were talking about. So we give them, and they know what the precautions are inside the Pilates world as far as working with bone density issues, and be able to say, here's a precaution. These are the indications. Want to work on these things. We want to get some mobility into, hip internal rotation in particular. They've lost a lot of that. And I think if we get that, and, moving these positions, they're going to come up with like 100 exercises.
yeah.
Yeah.
Yeah. And then in this case, it was like, we're going to avoid pain. So that was the guardrail, like no pain. But there are ways. I convinced myself through some exercises that I put her through, which I was using to judge whether or not what I was doing was helpful or not, right? So I'd find what we would call an asterisk sign. Oh, that hurts. So doing a squat hurts. Okay, fine. Or whatever the movement was. And then I do something, and then oh, that hurts less. I'm looking for a big change, 50% or better. Okay, that's better. And then I could go to Edie and go, I know she can do this movement with less pain. Are there ways we can do it with even less pain? And oh, here. Good, awesome. So that would be, yeah, given the guardrails and then some situations, some guidance, go for it.
I was also going to say, Rob, the other direction where Edie identified clients of hers that were having some pain or discomfort and brought them to you, and you brought them right back to her in conjunction and co-treating and then pushing them back into just being clients of Pilates, which is very much in harmony with our practice active physical therapists. Like we don't want to spend a long time. We want to be able to influence behavioral change. We want to be able to, influence any kind of tissue change that needs to happen for them to return to function. But we don't see ourselves as being, hey, you're going to come see your physical therapist 3 times a week for the rest of your life, kind of thing. But it does make sense for them to come in and do Pilates or practice Pilates at home 3 times a week for the rest of their life. That makes sense. And so it's such a nice mix. And again, whenever I say Pilates, I want to talk about all movement instructors. I think that whether you're a yogi or whether you're gyrotonic expansion system or Tai Chi or fitness in the gym or CrossFit, because a lot of it depends on what the client wants to do too and what they have access to. But our job as physical therapists is to identify that and see what in the community is going to work best in this transition. And I think it results in a much better outcome in the long run of people that are having behavior change, internal locus of control, body awareness, which we're really facilitating more in the Pilates. There is one thing that's very unique, and this is another one I'd love to hear your thoughts on, is the environment inside of Pilates is so aligned, especially with neuro rehab. You think of having the load modification, the orientation modifications, the length of levers modifications, all which are tools that are very fundamental in neurorehabilitation. And then thinking that we could continue that body awareness training with some of these clients outside of the supervision of a physical therapist by having good Pilates teachers that really know how to use the Pilates equipment to be assistive and to be able to understand changing orientation to gravity, to be able to create those positive movement experiences. And, how do we communicate that in a way that, is a positive movement experience for everybody? And what your thoughts are that maybe distinguish what we might experience on Pilates or the gyrotonic equipment, where it's built on an assistive model, sort of like what the old Guthrie Smith table was for polio.
Yeah, so I'll give you sort of 2 neurologic patient population examples. So the one would be, and I've worked a lot with this patient population, is Parkinson's disease. And they have a lot of musculoskeletal issues that, in my view, in my experience, result from their inability to move. So the Parkinson's disease limits or robs them of the ability to initiate movement. So they don't move as much, and so they get stiff. And so working on those mobility issues, clearly through working through Pilates and working on the equipment as needed and progressing towards the mat exercises as tolerated, is clearly beneficial for them. And we know, my colleague Beth Fisher was actually one of the pioneers in this area, that having patients that have Pilates, have Parkinson's disease, do exercise, and particularly high intensity exercise, actually alters the course of the disease, alters the neurochemistry that is producing the disease itself. And as she'll be the first to tell you, it doesn't matter what kind of exercise. It just needs to be high intensity, and it needs to be something that they're going to do, right? So as soon as you stop, as with most things exercise related, when you stop doing it, that the benefits decline. So so here's a patient population in which Pilates, I think, is super important because number one, we can alter the course of the disease. Number two, we can work on the mobility deficits that they always have. And number three, we create an environment in which they're engaged and willing and active participants in their exercise, and which is going to make it more likely they're going to continue and then lead to all the positive changes that exercise will give them. The other,
I was going to say, before you go on the next story, we had a group for 10 years that came in for the wellness side of our practice with Parkinson's disease. And, we made a video of it that's on YouTube. It's just Polestar Parkinson's. And what was interesting was we didn't realize what was going to come out of it. It was just a fun group. They'd come in, and if there's a birthday, they'd bring kazoos and they would do birthday things, and they would, have the most incredible discussions and fun talks and stuff. We had about 10 of them 10 individuals that came in for many, many years, and we had it subsidized. That was sort of our focus. But one of the leading outcomes we saw was, and this is what the neurologist said, is that they did not have to progress their synthetic dopamine, the L-Dopa that they were taking in those 5-6 years. That normally, that's the problem, is when the honeymoon's over of the first, couple levels of L-Dopa, then it's so severe that they have the secondary effects of the synthetic dopamine that now impact their ability to be in the community as much. But I thought that was interesting. It wasn't that we were curing Parkinson's disease with them, but we were definitely changing the projection of their disease. And you can hear them talking about it after they've been doing it for like 5-6 years in the video of what they had experienced from having a successful movement experience. And at University of St. Augustine, we have a rock steady boxing program, particularly for them. And that's another one of those. And I know that sort of ties into what you were talking about, where, it's just phenomenal to see how well they do after having strenuous exercise, crossing body patterns, and having so much fun. I think it's like,
yeah.
And they're with peers. I think that's
Yeah.
another key too.
Yeah. So, the group environment, the peer environment, all those things, having fun leads to, engagement, and the more engaged they are, the more likely they are to exercise. And the benefits are clear. Benefits are definitely there. So anything we can do to get them to exercise is going to be useful. So the other patient population that I would talk about would be someone who's had a stroke, right? And so if you have a hemiplegia on one side, we are very, very good at what we would call single trial learning. All I have to do is put weight on the hemiparetic side once and have it collapse under me, and I'm never going to do that again, right? And so they'll do whatever they can to avoid putting any weight on that limb, and to get off it as quickly as possible, which leads to very characteristic gait patterns. If we find ways, particularly early on, but throughout their care, to give them those positive movement experiences where, hey, I can put weight on this and it doesn't collapse. And that's what that feels like. Those kinds of experiences are huge. It takes a while to overcome that single trial learning. That's fear of falling and that experience, and a lot of those things factor into, okay, I'm never doing that again. But we can find safe ways to do them. So as an example, if you put them on the reformer and you get them weight bearing on that side, and you get them to be able to go through their range of motion under a load and realize that, hey, I can control this, and then over time gradually increase the resistance and increase their capabilities, that experience is huge. And I think there are a lot of ways. I feel comfortable with Pilates, but I certainly don't have the creativity and the depth and knowledge of the number and variety and diversity of types of exercises and activities that I've seen from the Pilates instructors that I've been around to come up with those types of things. But I would say, hey, can we find a way to have this patient weight bear, and not collapse? How, is there a way to do that? And then we could brainstorm and we can work it out and figure.
Well, and this is exactly what I'm after today, Rob, and I really appreciate this because I feel like this is the area that, sometimes a physical therapist feels like if they don't understand it all or have that repertoire that might exist in a good yoga teacher, a good Pilates teacher, a good gyrotonic teacher, that they get a little stifled. And I want them, when I'm teaching the students at the university in wellness and health promotion, it's like you need to go out and know who these practitioners are and have conversations. And it was interesting, one of the comments that came through, let me see who it was. Um, I'm in consultation with my PT. I always have him perform the relevant exercises and movements so that he understands them pragmatically and not just theoretically. So I thought that was, if the physical therapist, part of our assignment is they have to go out and experience some kind of complementary or alternative medicine experience and be able to report on what they felt and what they experienced with it. And this is, you know, one part of it of them having a greater appreciation of what they don't know, but they know somebody else now that does know it, and that I could communicate with them, and we could have this brainstorming of how we're going to meet the needs of the individuals, always individual centric. I also thought, when you were talking about, the beauty inside of the Pilates environment is definitely the fact that we can create these positive movement experiences, and we can create them without pain or that exceed expectations. And there's also one other component to it, which is the social component, which I think was part of what we see in Rock Steady Boxing and what we saw in the Pilates group class. Don Marie Ikes and Peggy Roller down in Southern California did that study, I want to say now about 5 years ago, just before COVID, but it's been one of the most frequently reported and used studies, juried articles that came out on Pilates has been used in other Pilates articles now. And what Peggy did, Peggy from the vestibular world, and Peggy created the study, designed it with a null hypothesis. There will be no difference. And they were looking at a population that was a high risk of falls. And they basically brought them into a Pilates class up there in the valley, and they had 6 people at a time, and they came in 2 times a week, and they did it for 12 weeks. And they were all high risk falls. They all inclusion criteria required that they have had made a visit to the hospital in the previous 6 months because of a fall. So already that they have this sort of mindset of, like you're talking about, which is the fear of falling, and it prevents them from moving well. Well, after the 12 weeks, they had 93 subjects. 3 did not finish the study, but of the 90, all of them came out of the fear of falling. So they were all extreme risk of fall, and they all came out of the risk of fall. So Peggy was blown away by it, and her commentary was so nice to have somebody that was looking from the outside in, not like she was petitioning for Pilates to be good, but she realized that, being in this group setting, having these positive movement experiences, there was nothing on fall prevention. It was a Pilates teacher teaching the class. There was no special exercises, but it was whole body exercise. It did take them up into standing. It did start them in supine. It took them through all the orientations that we would talk about in neurodevelopment. And they had this incredibly positive outcome. And the study was designed very well. And so I think that there's, multiple things besides that positive movement experience is being able to move amongst peers. Like imagine if we had, a class of people that had hemiplegia, and for them to have successful experiences, and people that had, children with ADHD. I mean, I could talk, all different things, people with cancer that are cancer survivors, and looking at how they have these positive movement experiences, how does it impact their belief, their ability to participate in their daily activities, their ability to feel more whole, more humanistic. These are the kind of outcomes that we really want to have. And sometimes if we're not communicating in this, movement world, we'll call it our movement world, from the patho world to the performance world, with that single focus of that individual being able to participate and having, for you to know, Rob, that you have friends and colleagues in the profession that have the repertoire. You don't have to know the repertoire. You just have to know to say what you want as a result and trust that they're going to use their skill base to be able to produce it. And they know that if they run into a concern or they have a fear of something, they can come back and ask you as the movement expert in pathokinesiology and say, I'm not getting the hip extension that I thought I would get, and she's complaining of a little bit of an impingement. You know, can we work on this together and maybe find some modifications to the movement?
I was, you know, amen to all of that, right? I was very fortunate because I was working out of or inside of her studio, right? So I actually used her Cadillac as my treatment table, and she had, you know, reformers in her mat and her floor space, you know, just right over there. It wasn't a big place, and so we were, you know, we're right there, and we're talking to one another as we're working, and you know, all the clients, they all knew one another. That's the kind of place that she
Right.
had, and so we had that. We didn't. It wasn't. There wasn't even a phone between us, you know, that would be a barrier. You know, there wasn't even email between us as a barrier. We could just talk to each other right there and go, hey, hey.
Nice.
So I found if I were to restart something like that, I would just put everybody in the same room, you know, the same place, and just make
Yeah.
it as accessible as possible.
Yeah, I love that. I think that would be, you know, uh, it's such a successful model. Now we've always lived with that model in Polestar, right? So we've always had that nice mixture of being in the same room, being in excess between the therapists and the Pilates teachers, and you know, progressive and group class. From a business perspective, you know, what we found, Rob, was we did a retrospective analysis of these patients that were discharged from physical therapy, and 40% of them continued in the Pilates practice. And then if they stayed there for, I think it was 6 months or 8 months or 9 months, something like that, the likelihood of them staying for 5 years was at 80%.
Wow.
So when you think of, you know, you talked about sort of something that was sticky or something that was, um, you know, appetizing to them. They feel so good doing it. They have a social component to it. It's very affordable. It's less than a, you know, copay. It's, you know, in the teens for every time they come in for a class. You know, this is something that, you know, just, you know, skip Starbucks a couple times a week and you have your Pilates class twice a week. You know, it's not inaccessible versus them coming to see me or you for $250 an hour or $300 an hour and get, you know, 50 minutes of our time or an hour of our time and be done without having to do that again. Where $300 could buy them, you know, 20, 30 sessions of Pilates classes over a period of 3 months. You know, it's like what we think of the business model, right? So what we found was we ran really two separate businesses. So we had our physical therapy with our EMR, with our insurance billing, and then we had our wellness practice. The gym space, however, was all shared. So the physiotherapist is out there working with their client and then saying, hey, you know, I want them to start seeing you. They weren't discharged yet, but I want them to start seeing you for some private visits to work on these things. They would work on those things, they would get better, we would discharge them, and then, you know, a lot of them, like I said, 40% stayed. Well, you can imagine, I won't go into the exact dollar amounts, but it was like, here was physical therapy earnings, here was Pilates earnings. Over a period of 5 years, the physical therapy earnings stayed the same, but the retention of wellness clients was, you know, off the charts. And so it created this nice environment. And then, you know, granted, somebody that had already rehabilitated, doing great, they're staying active, they go skiing, they get bumped by somebody, they hurt themselves, they have knee surgery. Where do they come? They come back to the physical therapy in the clinic there, and then they go through that cycle again of quality of life. And if you ask them what are they experiencing, they will tell you that, you know, this is a way that allows them to perform the things they want to participate in. And I think always going back to that language, what do you believe you should be participating in? What's your activities? What do you feel stops you from doing those activities? And then how do we find the solution to that? And if we do it as a team and we do it in the community that way, the client is going to be much happier, more successful, more likely to return to that activity. And, we're all fulfilling our roles. And that continuum can be skewed in different ways. Like we have PTAs that are Pilates certified that can do more of the rehab side as well as the continuum. And we have PTs that are certified in Pilates that can take them all the way through the wellness side of it. There was one other question that came in, and I didn't get a chance to answer it, but it was just talking about, people that have a heightened sense of awareness, of body posture, of movement awareness. She was asking if they actually do better in their rehabilitation, if that makes sense. Like if there's somebody that has good body awareness, are they going to do better or heal quicker than maybe somebody who does not have that body awareness? You want to take a shot at that?
Yeah, I think so. Certainly the opposite is true, that lacking body awareness will lead to problems. Maybe not right now, but down the road would be my guess. So we try to fix those, draw attention to them, fix whatever, but try to draw attention to them and get them to explore different movement options. So if I've given someone, more shoulder range of motion, hey, can you feel the difference? So I give them, before and this is where you're at, and after, do you feel a difference? Great. Well, let's move through that now. And now, great. So now with me, you've moved through that. Do you feel a difference? Okay, this is how I want you to move. I want here, move the old way. Now move the new way. Old way, new way, old way. What do you do differently? Great. That's what we want to try to work on.
Yeah. Rob, last question. We had just another minute or two, but it's sort of looking in the future and thinking of where do you see, if at all, the relationship of these type of, physio with movement practitioners, the dynamics of the insurance world, the professional world, what our organization's doing. Where do you see us going? Like, where would you like us to go in an ideal world? Where would you like to see um, that relationship of patho to performance kinesiologist as it pertains to our world, the way we look at things?
Well, I think the model that we've been talking about is a strong one, and I would like to see more physios who are in the world of teaching people how to move better. And that, when I say in the world, either they are learning how to do that themselves or they are aligning themselves with people who can help them do that. So that this model that we've been talking about, I think, is very important and something that we try to instill in our students as they graduate. Um, you alluded to this, that the PT reimbursements are here. They haven't changed in a long time, yet our expenses have gone up. And so the margins in a PT clinic have been shrinking for a number of years because cost of living goes up. So, it's not, we're trying to,
Always grow up.
yeah, we're not trying to, become millionaires on someone else's backs. It's just that's the way things that work. So I think that a lot of people a lot of physios are going to cash pay in order to make up the difference and in order to keep their clinics open. The problem I see with that is if we continue to do that, we get a two-tiered system in which people who don't have the cash, the disposable income, will not have access to that. And I would like to avoid that as much as possible. So, we try to push the consciousness of our students towards pro bono treatments and serving the underserved. So I'm a little worried that cash pay will go in that direction, though I think there are ways to have the cash pay support, the pro bono or support the serving the underserved. But I do feel that the combination, I think it's a very, very strong combination. And of course, I'm colored by my experiences, but a very strong combination to have what I can do as a physio, paired with what a Pilates instructor or a gyrotonics or, someone who's really a yogi, who can really work on their movement and move them down that road, and continue to have them exercise on a long-term basis.
Yeah. Thank you, Rob, so much. I really appreciate your insight and your leadership and your Forrest Gumpism is amazing. Like, just, I feel like you've been blessed, and I'm blessed to know you, and you've introduced me to so many amazing people over the years in our profession. And I do feel strongly, as you're saying, that, you know, as we as we break down some of the barriers and we look at, if you were to go purely on a cash base mode and you truly had compassion and empathy in our profession, um, you know, there is a way to make that model work. And I always tell my students in the business administration that, you should be allocating 10% of a well-run practice to pro bono. And if we're really looking at restoring function and using our ICF model, we'll also realize a lot of the resources in the community that can become extenders for us to be able to really create more successful experiences. When a surgeon looks at a hip, he or she is looking at surgery. When a medical doctor is looking at it, they're often looking at pharma. And a physical therapist is often looking at manipulation or, certain battery of exercises. And so, we all have our strengths, and thank goodness we have good surgeons. Thank goodness we have good pharma. Thank goodness we have good physical therapists, and thank goodness we have good Pilates teachers and gyro teachers. And I think the more that we can break through the bridges and realize, to me, earlier intervention with movement would eliminate a whole bunch of unnecessary pharma and unnecessary surgery, just like you had talked about with the hip client, and making it so that client has greater responsibility for their wellness. So there's whole nother conversation for another day. But how do we instill the responsibility for the client to know themselves, to have an internal locus of control, to realize that they need to do the movement, they need to participate in these tasks and these activities to be
So
healthy.
important.
Yeah, there's not a magic pill. There's not a magic surgery that's just going to solve everything. We need to be responsible for that. Rob, thank you so much. Great day. You and I could go on for hours, so we probably will set up another one in, a number of months, and we'll come back with a different topic. But I thank you, and long live pathokinesiology, and that it just excites me to even say the word. So, and keep the PK clinics open so we can learn about it, and have a wonderful week. I know you're off for a little bit from school, so enjoy the rest of your time before the new semester starts up. Everybody out there in Pilates Hour, thank you for joining us today. And always a pleasure bringing the world physical, emotional, and spiritual alignment. And we want to continue doing so. We love your feedback. So as we go through and bring different guests to you, if there's things that you can bring out, or you want to share, a thought that you had about something or something that really touched you, we would love to hear about it. It helps us to, ask the right questions. It helps us to bring on the right guests. It helps us to do a better job of bringing you awareness, education, and knowledge. And as I said earlier, you don't need a license to gain knowledge. We just need to know how we use that knowledge appropriately within the scope of our practice. With that being said, above all things, this coming weekend, be kind in the world, and we'll see you next week on the next Pilates Hour.